edition of teaching program of online, which the AOP UP is conducting every Friday 3 to 4 p.m. And this time it is under the presidentship of Dr. Alka Agrawal, madam. And I'll request our President AOP UP, Dr. Alka ma'am, to please welcome.
Thank you very much, Dr. Shalab. Dr. Sanjay Niranjan, our President-elect for the next year, respected Dr. Sethi sir, respected Madam Dr. Deepti Suri, our both the chairpersons and all the esteemed people who have joined this the activity today. So I think from the later part of the January, we've been continuously having, and this is the third activity that we are, the PG activity that we are having, and Dr. Shalab has been working extremely hard to bring you newer events which catch the eye of the postgraduates, and which is also equally important, as well as a good learning experience for the postgraduates. So I congratulate Dr. Shalab for such illustrious efforts that he is making. And another event which we are having today is an equally interesting topic, which is demystifying the human inborn errors of immunity, which will be taken up by a very learned speaker, Dr. Deepti Suri, and chaired by my dear friend, Dr. Ruchira, and who's also who's been working very hard for our Noida Pedicon to be successful, and Dr. Paramhansa. So over to you, Dr. Shalab, for the proceedings. Thank you very much.
Can you see my screen?
Yes, yes, sir. Yes, sir.
Okay. Yeah. So, first of all, before we begin with the talk, I'd like to introduce the honorable chairpersons. First of all, Dr. Ruchira Gupta. It's my pleasure to introduce Dr. Ruchira Gupta, very close friend and a colleague from AOP UP, past secretary of the AOP UP, and currently everyone knows that how hard she is working for the Gen Next Pedicon to be held in Noida. She has been the Central Zone Coordinator of IAP Women Wing, and President of the Academy of Pediatrics Noida, Secretary AOP UP Noida, and she is the editor of the Child Today and the technical editor contributor of IAP WW Parenting Module, and the Chief Organizing Secretary of the UP Pedicon 2008. And executive board member of the Central IAP 2014 and 19. And she's been the national trainer for various programs like HOPE, Appropriate Pediatrics, Therapeutics, Clinical Clues, NRP, etc. And publications of many in the books. And she's a very hard-working and a big pillar of AOP UP and the symbol of the women power, the emerging women power in the AOP UP. So welcome, Dr. Ruchira Gupta, and thank you very much for taking out this time from out of your very busy schedule. Thank you, Dr. Ruchira.
Thank you, sir.
And it's my pleasure to introduce Dr. Ramakrishna Paramhansa, our next honorable chairperson, who has been a very good academician, professional HOD from the GSL Medical College, Rajamahendram, and Central Zone Convener, online teaching modules of PG, and in the PG teaching program, it is already his passion. So it's our great pleasure to have him as a chairperson in this topic, which is very important, and university gold medalist and MD university topper, gold medalist in surgery, and it's a oration awardee in IMA National Conference, guest speaker in pediatrics, and so many guest speakers, and national coordinator of IPPG quiz. So he's a great academician, and it's I think the postgraduates will be greatly benefited. And just before I hand over to the chairpersons, I'd like to thank Dr. Deepti Suri, who is a very special speaker, a great academician of PGI Chandigarh, and my association goes from her from the days of MGMS Sevagram. Thank you, Dr. Suri, Dr. Deepti, for accepting to be the this talk, taking this time for this out of your busy schedule. Now over to the chairpersons.
Thank you, sir. Thank you, Shalab, sir.
Just
for the
a small correction here. She's now the doctor. It is now professor. Yeah.
Okay. So, Shalabh, can you please share her introductory slide?
Yeah, can you see the screen of her?
Yeah, sir, actually, I can see my slide only.
Okay, I'll just put it again.
Yeah, okay. So, thank you very much. At the outset, I would like to thank AOP Uttar Pradesh President Dr. Alka Agrawal and President-elect and the coordinator PG program, Dr. Shalabh sir, and President-elect Dr. Sanjay Niranjan sir, Secretary HSD Dr. Ajay Srivastava sir, for giving me this opportunity of sharing this platform with you all and to be part of this prestigious PG program, which is really a great program. I think the success of this program has been calculated in terms of the participation which we are seeing, which is really quite encouraging. So today's topic is very, very important topic, that is demystifying human inborn errors of immunity. Now, we all know that we have been discussing, and now more and more of our understanding about the infections and immunity day by day is improving with a lot of advances in research. And and this is one part I always feel is not, it's been taught in our medical school, but I think we are not giving that much of importance. We are giving more of importance to infections and other part of it. But when we actually go into our practice, or when we really do medicine in our real life, then we important, okay, how immunity is important and how inborn errors of immunity can affect the overall output of any disease and their presentations. And so this topic is very, very apt. And for that, we have, the speaker is, today's speaker is the master speaker. And that's why this is the master class by Professor Deepti Suri, additional professor PGIMER, Postgraduate Institute of Medical Education and Research, Chandigarh. It is Dr. She is known to everyone. She is the one who's pioneer, who's doing such a great work. Her present affiliation I've already shared with you. If you look at her publications, gosh, there are 236, enormous. That shows her passion for research and publication. Her areas, she has got a Commonwealth Medical Fellowship in Immunology and Bone Marrow Transplantation at Great North Children's Hospital, Newcastle, UK in 2019. And she also got training in immunological and molecular techniques for tuberculosis and HIV diagnosis in children at Lagoon Medical Center, New York University School of Medicine from United States of America. So looking at her grand sort of interest and her knowledge and her sort of expertise in this field, we are sure that we are going to have a great session. So I do not want to waste any of the time between the deliberation by Dr. Deepti Suri and our audience. So over to you, Dr. Deepti Suri, for your deliberation.
Thank you, Dr. Ruchira, for such kind introduction. And I must thank the IAP UP for giving me this opportunity to connect with you all. Dr. Shalabh has been my mentor and teacher during my undergraduate days, and my real gratitude to Dr. Sanjay Niranjan, Dr. Alka, and the co-chairperson, Dr. Ramakrishna and Dr. Ruchira. So this topic, as you all know, is a very topic dear to my heart. So human inborn errors of immunity, and that is the focus that we have in the unit. And these disorders, if you allow, I'll start sharing my screen. And So the topic is demystifying inborn errors of immunity. And as you all have heard, and as an undergraduate and even as a postgraduate, we were never taught about this entity called inborn errors of immunity, which are currently very well known as primary immune deficiency disorders. It was over the period of time that we started learning about these, and the more we investigated, the more we identified these patients. So today in the next 35 to 40 minutes, I would like to take you across simple clues in clinical practice that can help us recognize these disorders. And I want to emphasize that it is not that they do not exist or they are absolutely rare. So the screen moving. The screen doesn't seem to be moving. I'll share again. I'm sorry for that. Inborn errors. So what are human inborn errors of immunity? These are actually a group of disorders which currently are 430 single gene inborn errors of immunity. And as I said, these human inborn errors of immunity is a recent term that was coined in 2019. And previously, these disorders were better known as primary immune deficiency disorders. So what are they actually? There is actually a genetic defect which results in a physiological effect that results in aberrant immunity, predominantly presenting as infections or recurrent infections. But a very strong component of this aberrant immunity is immune dysregulation, and hence these patients also present with what is known as is autoimmunity, malignancy, and other immune dysregulations. So primary immune deficiency disorders manifest with increased susceptibility to infectious diseases. They have autoimmunity, autoinflammatory diseases, allergies, and malignancies. So this is actually the complete armamentarium of pediatric presentation in any office practice. And they are caused by monogenic germline mutations, as either resulting in a loss of expression of a protein or even sometimes gain of function of a protein. Over the years, worldwide, there has been a rapid increase in the number of immune PIDs or human inborn errors of immunity that have been recognized. And as you can see in this graph, the rapid escalation is actually attributed to a more availability of the genetic tests. So these group of disorders are not only common in worldwide, but even if you see in India, we realize that there is a marked escalation in recognition of these disorders. So just a brief overview of how our immune system works. Our immune system is essentially classified or divided arbitrarily into innate immune system and the adaptive immune system. Now, the innate immune system, what is known as the first line of defense, consists of a cellular component, and the most important cells in this are the macrophages or the neutrophils, and they secrete certain cytokines, chemokines, and the complements, which are a part of the innate immune system. They are the first line and the immediate reactions that occur once the pathogen is encountered by our body. While the adaptive immune system is a rather second line of defense, which consists of the T cells and the B cells, and the B cells and the plasma cells then produce the antibodies, which is the molecular compartment. Both these compartments do not have a very strong interaction between each other, but essentially for the sake of convenience and understanding, the two immune systems are arbitrarily divided. Now, the categories of PIDs, according to 2019, is therefore classified into 10 such components, and the important ones are the combined immune deficiencies, that is affects both the cellular and the humoral immunity. Then we have some combined immune deficiencies with syndromic features. Then only essentially when the antibodies are deficient, There are immune dysregulation syndromes, the defects in phagocytes, the defects in the innate immunity. Again, in the innate immunity, we have autoinflammatory diseases, complement deficiencies, even the bone marrow failure syndromes, that is the Pearson marrow and the early bone marrow failure syndromes are also included under the inborn errors of immunity. And of course, then the last one is the phenocopy, in which there is actually not a genetic defect, but antibodies that are produced which result in presentation like a primary immune deficiency disease. But for the sake of convenience and for the sake of understanding initially, I'll just talk about 4 important components, that is the antibody defects, the combined defects, the phagocytic defects, and the innate defects. So the prototypes of antibody deficiency is when there is essentially no antibody production. This is X-linked A-gamma globulinemia, while what is seen in later in life is common variable immune deficiency. So these are 2 essential prototypes of pure antibody defects. The combined defects are what is we all know is a severe combined immune deficiency, the syndromic ones being Wiskott-Ulrich syndrome, the Dye-George syndrome, and the hyper-IgM syndrome. Among the phagocytic defects are the prototype can be taken as chronic granulomatous disease. Then we have the neutropenias, that is the cyclical and the congenital neutropenia, and leukocyte adhesion defects. While in the innate defects, we would just touch upon the complement deficiencies and the Mendelian susceptibility to mycobacterial diseases. So this was in 2007 when we celebrated the World Immunology Day, and we brought out a news line saying that most immune deficiency cases go undiagnosed. And there were just a handful of patients whom we had diagnosed at our center, and we were struggling to help these families get treatment. So contrary to the common perception that PIDs are not common, the estimated prevalence is as high as 1 in 1,000 in certain consanguineous countries, while 1 in 5,000 population. Hence, in India, there are more likely to have around 1 million children with primary immune deficiency disorders. So diagnosis, however, is not difficult. It is possible for us to make a syndromic diagnosis of PIDs at bedside, and that is what I'm going to talk about. So when should a clinician suspect immune deficiency in a child? Essentially, when a child has very frequent or recurrent illnesses. However, when a child with recurrent illness comes to an office or for a consult, pediatric consult, one would think essentially 50% of these times the child is going to be normal. And they would, because most children have upper respiratory tract infections because of viral infections, and there is something called physiological immune deficiency of immaturity, and children less than 5 years of age usually have recurrent pediatric office visits for simple upper respiratory tract infections. A significant amount of patients would actually have allergies or atopy and bronchial asthma. However, it is important to recognize that usually atopic children will have normal growth and development, and there can be a suggestion of a family history of atopy. Around 10% of children will have underlying congenital chronic conditions like a congenital heart disease, a cystic fibrosis, or failure to thrive, and they will specifically have failure to thrive. They'll have sick appearances and have an underlying anatomic defects. Now, after we rule out all these things, then comes the immune deficiency, and then it can be a primary or a secondary immune deficiency. So whenever children have very frequent infections, it is not only frequent, but whenever they have very severe infections, when you have an unusual clinical presentation or a complication, say for example, a salmonella infection resulting in a splenic abscess, this is unusual, though well known, one should think of an underlying immune deficiency. Or if there is an infection with an unusual microorganism, for example, Burkholderia cepacia or a nocardia, or you identify a weird organism, then probably one should think of these commensals or less virulent organisms causing disease in a child, suggesting, which may even be the first manifestation suggesting that this child could have an underlying immune deficiency. Even in patients when there is failure to respond to standard therapy, a pneumonic illness is getting complicated again and again, and it's not responding to sensitive antibiotics, that is the time that one has to think that probably this child has something more than simple immune deficiency, has an underlying immune deficiency. Not only, as I've been emphasizing, not only are the patients supposed to have an underlying infection as a manifestation alone, but it is important, and I'll take you through some examples over the talk, are the autoimmune diseases, the rash, the arthritis, autoimmune hemolytic anemias, inflammatory bowel disease, even lupus and lupus-like syndromes, especially resulting because of complement disorders, malignancies, especially EBV-related malignancies, granulomatous diseases, allergies, adverse reaction to vaccines. Now, this is a very important presentation. A child who develops a very adverse reaction to vaccine, one has to think of an underlying immune dysregulation, why a particular child is unable to handle a particular vaccine, and periodic fever syndromes. So when should you not suspect? We usually do not suspect if there are recurrent upper respiratory or viral infections. Recurrent urinary tract infections are more likely to occur because of anatomic defects. If there is a first episode of meningitis or recurrent neonatal sepsis or sepsis occurring in pediatric ICU, otherwise the child is doing well, we need not always suspect an underlying immune deficiency. Now, this is the first child, a 5-year-old boy who had failure to thrive, recurrent febrile episodes, otitis media, diarrhea, needed anti-tubercular therapy. Mother had died 2 years back, oral thrush, generalized lymphadenopathy, parotid enlargement, scabies, crepitations, and hepatosplenomegaly. Now, there is sufficient information here to suggest that this child is not doing well and there is an underlying immune dysregulation, immune deficiency here. And the child had anemia, leukopenia, thrombocytopenia, reversal of AG ratio, elevated in transaminases. In this child, the first test that was ordered because of the maternal death was HIV, and this child had a reactive HIV serology. So secondary immune deficiencies are more common than primary immune deficiencies and must be ruled out before you take up the entire extensive workup for a primary immune deficiency disorders. So we suspect secondary immune deficiency not only with HIV infections, but also in association with nephrotic syndromes, malignancies, and if the child is receiving immunosuppressive therapies. So now I'll talk essentially on the primary immune deficiencies, and we believe that secondary immune deficiencies have been ruled out. Now, there is a three-pronged approach which must be followed in all patients with primary immune deficiencies, and the three important clues are the age of presentation, the type of organism, and the family history. Now let's look at age of presentation. If we look at the ontogeny of immune deficiencies, the first 6 months of life, that is from birth to 6 months, the presentation is essentially seen in patients who have cellular immune defects. This is because the transplacental transfer of IgG protects the child in the first 6 months. So pure antibody deficiencies will be protected even in the first 6 months of life, and more than 6 months of life, the humoral defects are more likely. Having said that, it is not a complete strict rule. However, it is important that early presentations, one would think of a more severe disease in which there is a combined cellular as well as humoral deficiency. This is the way how serum immunoglobulins change with time. And as you see that there is a dip in the maternal IgG with time. And for the first 6 months, the child is protected because of the transplacental transfer. So the first few weeks to months, it's SCID. From 6 months to 5 years, you have humoral antibodies like XLA and Wiskott-Aldrich syndrome presenting. More than 5 years, more common ones would be the common variable immune deficiencies or the specific antibody deficiencies. Moving on to the family history, to the type of organism. So in the cellular defects is these patients have predilection to develop all kinds of opportunistic infections. So right from pneumocystis cerevisiae to mycobacterial, because they have received BCG vaccine, fungal infections, viral infections, and bacterial, they have essentially no defense, and they will will present very early in life with all kinds of opportunistic infections. Humoral defects, patients are usually able to handle the viruses very well, except for enteroviruses. They have infections with encapsulated bacteria. They have classically difficult to control giardiasis, and they have problems with enteroviral infections. Phagocytic defects, CGD, they have problems with catalase positive organisms, Staphylococcus, Serratia, Aspergillus, and Candida. While complement deficiencies, we know the Neisseria infections and encapsulated bacteria can cause difficulties in patients with complement defects. Moving on to family history, these are genetic disorders, hence family history is always important. We look for whether there is history of a suggestion of an X-linked recessive disorder, or if there is an autosomal dominant disorder seen in both the father, mother, and the child, or is it an autosomal recessive disorder, which most of the other ones are, and very common in consanguineously married families. So the second child, after this background information, we'll look at the second child, who was a 2-year-old male who was symptomatic since 6 months of age. He had 6 months of age and he acquired the first episode of a pneumococcal pneumonia and 2 episodes of otitis media. His 2 maternal uncles had died at 2 years of age with similar complaints. There were no palpable lymph nodes on examination and tonsils were absent. So there are recurrent sinopulmonary infections suggesting a humoral defect. There is a history of 2 maternal uncles who had died, so suggesting an X-linked disorder, and there were no palpable lymph nodes or tonsils. And as you can see that the child had presented for the first time beyond 6 months of age, the most likely diagnosis here is likely to be an X-linked A-gamma globulinemia. So when we have a general approach to PIDs, we take a detailed history and physical examination, specifically looking at the tonsils, the lymph nodes, and presence and absence of hepatosplenomegaly. Then we look at the complete blood count. Now, this is the first and the foremost important investigation that we must perform. There are serum immunoglobulins, and then we look at the flow cytometry using T, B, and NK cell. These are the essential tests that we have to do, and formally we can also look at the protein estimation. If we do not find defects in the quantity, you can sometimes do functional defects because the quantity can be normal, but the function can still be abnormal. And lastly, one would resort to a genetic confirmation by molecular sequencing or by a next-gen sequencer or a Sanger sequencing. So this was the child that we were thinking clinically that could be having an X-linked A-gamma globulinemia. We do a complete blood count. The complete blood count is essentially normal, but we resort to the second step, that is serum immunoglobulin estimation. And we realize that all the 3 immunoglobulin fractions, G, A, and M, are reduced. We look at the flow cytometry to look at the percentages of CD3 and CD19. That is, CD3 is the T cell marker, while CD19 is a B cell marker. And we, with the help of the flow cytometry, we estimate the B cell numbers. And in this quadrant, in the second picture, you can see this, there is absolutely no CD19. And this confirms the diagnosis of XLA. We can also look at the expression of Proton tyrosine kinase expression. Now, XLA is caused by a mutation in BTK gene, and this gene expresses a protein called BTK protein. This protein can also be estimated in the lymphocytes of the patients. And you can see in this graph here, there is no protein. That means there is no shift from the red peak to the green peak as seen in the control. The green and the red peak overlay each other, suggesting that there is an absence of BTK protein and thereby confirming the diagnosis of XLA. Now, this is a child who had come from Assam to us with swollen PIP joints and knee joint inflammation suggesting arthritis and was referred as JIA to us. However, when we just reviewed the history, there were 2 episodes of pneumonia and 4 episodes of ear discharge. And this child was also diagnosed to have an X-linked A-gamma globulinemia. So arthritis is also an important presentation. It can be pyogenic arthritis or septic arthritis, but inflammatory components are also seen in these patients. And this patient had a seronegative polyarthritis because of, essentially, this is because of ureaplasma or mycoplasmal infections, presenting as JIA. This is a 5-year-old boy who had come with focal seizures, epilepsy partialis continua. There was a past history of pneumonia, and this is the MR suggesting hyperintensities. What was again important was a clue that this child had just recently received a poliovirus, oral polio vaccine because of pulse polio program. And this was a child with X-linked A-gamma globulinemia who had developed an enteroviral meningitis because of the recent pulse polio dose. Are PIDs seen only in patients who are children? No, PIDs are also seen in adults. So there's a 21-year-old male. He had chronic fever and cough. He had ankle arthritis. He was diagnosed to have celiac disease 2 years back and was on a gluten-free diet. He came to us with persistent pyrexia. He had mediastinal lymph nodes. Tuberculosis was suspected again. And what the FNAC revealed was a non-caseating granuloma with T-cell predominance. The adults were considering a possibility of sarcoidosis in this patient. However, a simple test like an immunoglobulin profile helped us clinch the diagnosis of common variable immune deficiency. Now, this patient had very low immunoglobulin levels, IgG, IgA, and IgM, which were very low than the normal. And he underwent a lymphocyte subset analysis. CD3 were normal, but CD19 was also normal. But in view of a normal CD19 and low immunoglobulins, the diagnosis was made of a common variable immune deficiency. And these granulomas, which are seen in these patients, are actually immune dysregulation, and they can be formed not only in the lymph nodes, but in many organ systems like gut, lymph nodes, liver, and are often diagnosed as tuberculosis versus sarcoidosis. So what is CVID? It is reduction in serum immunoglobulins by 2 or more standard deviations. There is a loss of specific antibody response, which we assess by giving vaccines. And when the T-cell defect is ruled out, we would like to label these patients as common variable immune deficiencies. So when do we think of common variable immune deficiencies? We think of common variable immune deficiencies when children or patients present with AIHA or ITP-like illness, when they have granulomatous inflammation, when they have IBD-like illness, when they have recurrent sinopulmonary infections, unexplained bronchiectasis or giardiasis, and often these patients also develop lymphomas and GI malignancies. So what are the basic defects? In XLA, a stem cell which gets converted into pro B cells and mature B cells. And it is the BTK which is required from conversion of pro B to B. While in CVID, the defect rise from the mature B cells to plasma cells. Hence, in flow cytometry in XLA, you would find absent CD19, while in patients with a CVID, you would find normal CD19 levels in the peripheral circulation. Moving on to the combined defects, classic history is in a child who's not doing well, having recurrent loose stools. And this, I feel, is a very important clue when the child develops loose stools despite exclusive breastfeeding. He was not thriving well. There was a family history suggestive of X-linked disorder, and this child had a lot of subcutaneous abscesses, oral thrush, and an absent tonsil. This is the X-linked history, and a complete blood count at this stage was a very important investigation, and it led to the diagnosis. Now, if you look at this complete blood count, it appears apparently normal, and we are so attuned to seeing the polymorphic response in sepsis. However, we have to get into the habit of calculating the absolute lymphocyte count also. An absolute lymphocyte count of less than 3,000 in infancy is very suggestive of a severe combined immune deficiency. Now, if we calculate the absolute lymphocyte count here, it is only around 1,995. So X-linked disorder, early infantile deaths, and lymphopenia are significant suspicion is on an X-linked SCID. We look at the immunoglobulins. Immunoglobulins seemingly appear normal with IgG of 586. But one must remember that this is a fallacious report because in severe combined immune deficiency, you expect both humoral, that means antibodies, to be low. But here IgG is normal. This is because this IgG is actually transplacentally transferred maternal IgG, and hence it may appear normal. But what is important is the lymphopenia, which is a very important test and calculation to be made when we look at neonatal sepsis. The child underwent a lymphocyte subset analysis. The T cells were only 2%, B cells were normal, and NK cells were also low. So T negative, B positive, NK negative SCID. So this is an X-linked SCID, which was because of common gamma chain and confirmed genetically subsequently. The FNAC of the subcutaneous abscess revealed this, it was laden with AFB, and this was confirmed to be the BCG. So dissemination of BCG in these patients can result in subcutaneous nodules, hepatosplenomegaly, lung and liver involvement. And we have to be very careful in counseling the families not to give BCG subsequently if we lose these children in the next born child. The bronchoalveolar lavage revealed pneumocystis cerevisiae, and the diagnosis of SCID was confirmed. So it's a more serious form of combined immune deficiency with children presenting with T cell, low T cell number, absolute lymphocyte count of less than 3,000, and they should be confirmed with to have an underlying immune deficient genetic mutation. So patients with SCID present with opportunistic infections. They have failure to thrive, diarrhea, SIB deaths, persistent lymphopenia, absent thymus and lymph nodes on tonsils. But what is most important is that you suspect severe combined immune deficiency. I'll take, so what is important is that that we do a flow cytometry, and this flow cytometry with T, B and NK cell will help us identify the underlying genetic candidate gene that we are thinking could be the cause of SCID. SCID is now a part of a newborn screening program in most of the, in US and quite a lot of European countries. And they do what is called as a TREC assay for early identification of patients with SCID so that they can undergo a bone marrow transplant. I'll move on to the other innate disorders. This was a 3-year-old child who had history of pneumonia and delayed umbilical cord separation, omphalitis, and large perianal ulcer. Again, only complete blood count was helpful because if you look at the polymorphs here, you realize that the absolute lymphocyte, the neutrophil count is as high as 60,000 and 43,000. Another child with such ulcerative lesions, and you can see that there is marked absence of pus formation here. There is hardly any pus formation with a lot of ulceration, and this is important because patients with leukocyte adhesion defects do not have pus formation. So this is also a complete blood count should not be interpreted as sepsis alone, but something more than that in such patients. And a simple test like CD18 can help you identify the leukocyte adhesion defects. A child from Baroda who had these kind of large ulcers, multiple of them from early childhood. These were diagnosed as recurrent pyoderma gangrenosum lesions requiring a lot of immunosuppressive therapy, also had nothing else but a leukocyte adhesion defect, and he had a low CD18. So this disorder is a migration disorder in which the cells are unable to egress out of the blood vessels to the site of infection and can be thought of in patients who develop recurrent bacterial infections, have large ulcers with no pus formation, delayed umbilical cord separation, and marked polymorphonuclear leukocytosis. Similar lesions are also seen in patients who have another innate defect, that is a neutrophilic defect. So this child, again, you can see that there are large ulcers, non-healing in nature. And in this case, it is actually neutropenia. And you look at the absolute neutrophil count is only 272 in this child. And this child had normal immunoglobulin. And if all that we did was just plot the absolute neutrophil counts, which the child had been having since early childhood, and we realized that there was a cyclical pattern to this neutrophil count, and this child had nothing but a cyclical neutropenia. A bone marrow examination is helpful because in such situations you can look for maturation arrest. There is a maturation arrest from pro-myelocyte to myelocyte, and subsequently can be confirmed on the basis of a genetic test, and this child also had an ELAN mutation. So cyclical neutropenia should be suspected in patients who have oral genital ulcers, gingivitis, periodontitis, and recurrent pharyngitis. They can be managed very well with simple GCSF injections, and they can be subsequently taken up for transplantation. So this is the child. She's actually, this is an old picture. She's around 10 years of age now and doing really well. So syndromic PIDs, this was a baby who had come from dermatology for atopic dermatitis. And you can see that there was a lot of atopic skin lesions. What was also intriguing was the mother complaining of epistaxis in this child. And this led to the referral from the dermatology unit to our unit. And on careful examination, there was one episode of pneumonia also. Again, a complete blood count gave us the clue. Though the absolute neutrophil count and absolute lymphocyte count was normal, here it was the platelet count that was low. And this child, immunoglobulin profile revealed a normal IgG, raised IgA, a raised IgE, and a low IgM. So now this is a typical pattern that we see in patients with Wiskott-Ulrich syndrome. So all that we did was a complete mean platelet volume, and MPV needs to be calculated in every male child presenting with thrombocytopenia. The normal MPV value is 7 to 12, while in the index child it was 5. So microthrombocytopenia is an important clue to diagnosis of underlying Wiskott-Ulrich syndrome. And essentially, this is from the textbook saying that low MPV, the diagnosis of Wiskott-Ulrich syndrome should be confirmed. So the child underwent a WASP assay. Another child who had severe varicella infection with persistent thrombocytopenia, a child with recalcitrant glaucoma because of cytomegalovirus infection, had underlying persistent thrombocytopenia, which was labeled to be secondary to CMV infection, actually turned out to have Wiskott-Ulrich syndrome. Now, this child was having a typical purpuric lesion or HSP. Now, we sometimes don't even order any test for HSP, but we suspected that the child could be having other illnesses, and what was the clue was in HSP you want the patients to have thrombocytosis, while this child had thrombocytopenia. And skin vasculitis is a very common cause of common presentation of patients with Wiskott-Ulrich syndrome. So suspect was in patients who have persistent thrombocytopenia, small platelets, blood in stools in early infancy, all cases with chronic ITP, X-linked family history, infections and atopic dermatitis, and autoimmune manifestations. A child with hydropneumothorax, he gave history that I have to undergo a dental procedure, and all that we saw was retained primary dentition, and this child was diagnosed to have hyper IgE syndrome. Another child in patients with hyper IgE syndrome develop these coarse facies, but which were not very evident in small children. But if you look carefully, the father, he also used to have recurrent pneumonia, skin abscesses, and had been treated for tuberculosis. While the coarsening of faces, that is the bushy eyebrows, the broad nose, is well recognized in patients with hyper IgE syndrome. A child with recurrent molluscum was diagnosed to have Dockade deficiency. Another important part will be chronic granulomatous disease. Now, these are the patients who present again with recurrent infections, while sinus formation and recurrent liver abscesses. These patients have increased inflammatory responses in the form of thrombocytosis, high ESR CRPs, of elevated white blood count. And even the immunoglobulins are high, it is not low. But a test that is important is NBT, and these tests and a DHR, which can help you clinch the diagnosis of CGD. So CGD can be diagnosed on the basis of NBT and DHR test, and they have clinical presentation in the form of lymphadenitis, fungal pneumonias, recurrent lung and liver abscesses, osteomyelitis, and granuloma formation. A child with multiple lytic lesions in the bone was thought to have tubercular osteomyelitis, but when we looked more into detail, what this child had was a Mendelian susceptibility to mycobacterial diseases. So this is the child with recurrent tubercular osteomyelitis, and one must suspect underlying immune defect whenever we think of a osteoarticular TB. So this is the infection profile of patients with PID. How do we manage them? We manage them essentially with prophylaxis. We give them cotrimoxazole or azithromycin prophylaxis. We even give them immunoglobulin replacement therapy so as to maintain their immunoglobulin profiles. And this is specifically true in patients who have antibody deficiencies, while a curative therapy is in the form of a bone marrow transplant, essentially needed for all patients with severe combined immune deficiency and Wiskott-Aldrich syndrome. So antibody deficiencies can be managed with immunoglobulin replacements and antibiotic prophylaxis. Combined defects can be managed with transplants, while phagocytic defects can be handled only with GCSF or therapies. Now, in India, most of our patients are unable to afford transplants, and the triangle is inverted, but we are trying our best to turn over this triangle to get a transplant, to get more and more children undergo bone marrow transplants. So the key to the diagnosis is suspicion, family history, a complete blood count, immunoglobulin profile, and of course, you can then think about doing flow cytometry and next-gen sequencing. So a detailed history, recognizing the pattern, following simple diagnostic algorithms, complementing them with molecular testing is what is needed for diagnosing primary immune deficiency diseases. So I would just take you through this proverb that we say that when we hear the hoofs beat, usually one thinks of horses, but one must think of zebras also, and primary immune deficiency disorders or human inborn errors of immunity are zebras of the medical world. So this is our PID family. Most of the children have now grown up and doing really well. With support from governmental and non-governmental organizations, they are undergoing treatments. Thank you. I think we still have 10 minutes.
So it is a very mesmerizing presentation, especially the wide spectrum of cases, the plethora of different kind of case scenarios you have shown, Dr. Deepti. Really mesmerizing one. I will request my co-chairperson, Dr. Paramhansa, to kindly share his views and give his comments, and then we can take question and answers further. Dr. Paramhansa, please.
Thank you, ma'am.
Thank you. Thank you, Ruchira madam. Good afternoon, everyone. We had an excellent, wonderful lecture from the speaker who made things very easy. Why hundreds of people will not attend a topic like this is they are afraid of lot of inhibition. They think that we don't know much about immune deficiency. That's why that inhibition makes people keep away from the subject. But we cannot afford it. The reason being, more and more cases are being diagnosed with better awareness, better diagnostic modalities, and with focused examination. A few comments, of course, I am not that guest to comment on talk on immunologists. A few points from my side. The commonest cause baby. The baby is to be diagnosed at an earliest, not only to prevent the complications, morbidity, and mortality, and that is the period, early infancy, the period when we do vaccines. There are certain vaccines which cannot be given. So we have to, otherwise they may cause severe problems, serious problems, right? And ma'am, can I ask a few questions in the chat box? How early the cyclic neutropenia, any relationship with cyclic neutropenia with pancreatic involvement?
Yes, so cyclical neutropenia in Schwarzman-Diamond syndrome, you can have pancreatic involvement, and these patients present with neutropenia. So pancreatic evaluating for pancreatic dysfunction is important in patients in whom you not only suspect cyclical neutropenia, intermittent neutropenia, or persistent neutropenia. And what we are actually looking at is the Schwarzman-Diamond syndrome, which can present with pancreatic involvement. So we usually do a stool for fat globules. We do a detailed ultrasound and lipase and amylase levels to look at pancreatic dysfunction. It may evolve over a period of time. It may not be present when you see the child for the first time.
And there can be history of cystic fibrosis in such patients,
Yeah, sure.
and along with some osteopathies, etc.
Bone disease,
bone diseases also seen.
Ma'am, whether severe malnutrition can produce thymic aplasia?
So severe malnutrition can definitely lead to immune dysfunction and immune deficiencies. Corticosteroids are more common in causing the thymic involution than malnutrition alone. It cannot cause aplasia, it can cause involution to some extent, but this concept of malnutrition causing immune deficiency, I think I would like to reverse it. It is because of immune deficiency, recurrent infection, that the child becomes malnourished.
But just one caveat is the malnutrition is very, very common in our country. We don't expect so much of it because of immunodeficiency, right, ma'am?
Sir, if you can keep the child in your follow-up, improve nutrition, and even then, if the child is having multiple infections, then probably you have to think about it.
A tricky question, ma'am. Is there any specific reason why the card detachment is delayed in case of LAD? There is an observation. Is there any mechanism how it is?
You need intact neutrophil function for separation of umbilical cord. So the neutrophil actually are the first line of defense, and they'll reach the umbilical site and cause the separation of the cord. When in LAD, the neutrophils cannot egress out and reach the site, and hence that is why the separation of the umbilical cord gets delayed. It does happen, but it gets delayed. Often you have an unhealthy umbilical stump initially, and it can then secondarily gets infected to form an umbilical abscess. but the neutrophil function is needed for separation of the umbilicus cord.
A few recommendations regarding vaccines vis-a-vis combined
So
immunodeficiency.
I really want to suggest a couple of things that patients in whom we are suspecting. We often lose children with severe combined immune deficiencies. They reach late to us. But I think if we have had this suspicion and we have lost the child, two things that can be done at peripheral level is store a blood sample of that patient for further genetic analysis, and two, ensure that the parents can be instructed that birth dose, BCG and OPV should be withheld in the next child at least, so that next born child can first undergo certain tests and SCID can, or severe immune deficiency can be ruled out. So this is a standing instruction to all patients in whom we have lost even before the genetic diagnosis could be established. So we must ensure that live vaccines should not be given to these patients.
How about yes, please.
The killed ones can be given.
Killed ones can be given. However, I mean, these patients may get some suboptimal responses.
Yes.
So the schedule is different and we need to give higher dosages or higher, amount of vaccine. So that is one thing. Yeah.
Regarding rotavirus, ma'am?
In pure antibody deficiencies, often some people say that giving vaccine will not produce an immunoglobulin response, so they are of no use. But because they cannot mount immune responses, they are A-gamma globulinic. However, there are certain units which still go ahead and give for whatever it may be useful, but live vaccines are a big no.
There is a question from Dr. Sanjay Niranjan, sir, and he's, his query is that, is there any role of PIDs in patients with IUDs or high drops or SIDS?
I mean, what immunodeficiencies can cause IUD or high drops or sudden infant death syndrome?
Sir, what percentage of PIDs? These are genetic defects. So obviously, if you have patients who have genetic defect, nature can sometimes can cause abortions and early first trimester pregnancy. However, maternal milieu is usually protective, and these patients become symptomatic later in life, I mean postnatally. So they can contribute to early trimester abortions, but we don't usually take that as a very important history. There are more important reasons for IUDs, and I would personally not want to think that PIDs contribute to IUDs. They could be contributing to early first trimester abortions, but not to, there is no such history, late IUDs or eye drops.
Thank you.
Do you recommend mass COVID vaccine in children? No.
In general, or are we talking about immune deficiency children?
Right.
So in immune deficiency children, there have been debates in our forums whether COVID vaccines should be given to these patients, and generally we are still recommending to, according to the national guidelines, the kill vaccine in these patients, and even patients who are on immunosuppressive therapies. But other than that, there is no specific recommendation of using COVID vaccine specifically in these patients. What has happened with COVID and immune deficiencies is that these patients have known to retain their SARS-CoV-2 virus for a longer period of time. They don't become negative as early as we see in other children. But whether they are killed virus, so that's all debatable.
Madam, a little bit to add regarding blood transfusion, and you have to enlighten us regarding irradiated blood.
Yes.
Only can be given, lest it may cause GVHD.
Yes,
Because most of us would like to know more
very-
practical points.
Very clear, sir. Very important, and thank you for bringing that point up. Whenever we suspect a severe combined immune deficiency or any other immune deficiencies in whom we are contemplating transplant, we don't like to give them much blood transfusion. We must restrict, because transplant outcomes, the lesser they are sensitized, the better it is. And two, even if you have to give transplant, this should be a irradiated blood.
Just a few points about next generation sequencing and genome editing technologies, ma'am. A few points, just very brief, for want of time, right?
Actually, I have a class.
She has a class at 4 p.m. She had requested to close the session at 4.
So
Okay,
I'll just quickly
last
take over,
okay.
sir. Genomic sequencing, there are three essentially: a candidate gene approach and exome sequencing. So if you have, like, we have done a detailed evaluation, we have reached a diagnosis of XLA or CGD, and we know the candidate gene, then we can do the candidate gene approach. But nowadays, commercially are available the panels, and we can directly do the panels. The panels are becoming cheaper nowadays, from 16,000 to 30,000, and often it is just sending the panel away, but that is not a very good practice. You should first think what we are thinking, do a clinical evaluation, be sure that you're dealing with immune deficiency, and not just send a commercial panel.
Right.
So,
So,
thank you,
Dr.
sir.
Deepti, your talk was really, you made a complex subject so look so easy, and it's really, as you told, that we prime the audience to pick up these disorders which are not very commonly thought of.
Yeah.
And I think we'll
Thank you.
preserve this talk on our YouTube channel
Sure,
of
sir.
UP Pedicon,
Sure,
AOP UP. And I request our AOP UP's President-elect Dr. Sanjay Niranjan sir to please propose the vote. Thanks. Mute, sir, unmute. Unmute, Dr. Sanjay Niranjan.
Okay. So thank you very much, Dr. Sarab. So really well and carefully chosen topics. Till that topic started, I was thinking it was on inborn errors of metabolism. As I read inborn errors, I have never heard the term inborn errors of immunodeficiency. This I only realized when the topic started, truly speaking. So, and really demystifying is the term. So, thanks to the speaker, Dr. Deepti, very well done. I think when we are not able to save a child, I was posting a question, what sample should we take to prove that it may be immune deficiency, it may be due to environmental metabolism, because many times we do everything, still we cannot save a child. So you should be in the defense panel of if there is any litigation, so that we can say that these are the possibilities why we could not save. My thanks to Dr. Ramakrishna Paramhansa for chairing the session from Andhra Pradesh, and my teacher, Professor Rohit Shetty, and Dr. Gupta, and all the participants. So this PG class is really being very, very popular and very, actually, very informative as well. Teaching experience for all of us. Thank you very much.
Thank you, sir. I also enjoyed the interaction. Thank you.
Thank you, Dr.
Thank
Ruchira.
you,
also,
madam. Thank
our
you, Dr.